To today's special VMR. We have a very special episode today, second episode in our CPS Bootcamp. I'm going to start sharing the screen. Give me a second. All right, so everybody, I guess somebody tell me if they can see the screen.
Yes.
Oh, you see it? Okay, all right. So we'll get started. So again, everybody, welcome to today's episode. This is a special Sunday VMR.
Oh no, Robbie, I think you clicked mute.
You're muted.
Thank you. Yeah, when I have the slides up, I can't see the background though. So again, everybody, welcome to today's episode. This is a very special episode. It's the second in the series Clinical Reasoning Bootcamp with our team from CPS. We really hope in the next hour we can show you another important tool that is used in the process of clinical reasoning, which is the illness script. Madalena?
Yes, so welcome everyone. I'm so excited for today's session. So today we will continue on with our journey through the mechanisms of clinical reasoning. As some of you may have tuned into last time on our last episode, we focused on the impact that the problem representation has. And today we will show and demonstrate the usefulness and the impact that the illness script has in making a differential diagnosis.
Before we get moving, I'd like to introduce the crew that has made this bootcamp possible. We'll start with Marcella on the top left.
Hi, everyone. My name is Marcella. I'm a doctor from Brazil. Outside of medicine, I like to cook and to read books. And I'm really excited to be here with you all today and learn a lot. And I pass the mic to Madalena.
Yes, hello everyone. My name is Madalena. I'm a medical student in New York City. And something about me outside of medicine, I love to meet new people. And because I used to be a figure skater, I love to watch the sport and sometimes practice too. I'll pass the mic to Shema.
Hello, I'm Shema and I'm a fifth year medical student in Berlin. And outside of medicine, I enjoy true crime documentaries and also spending time with my friends. So I pass the mic over.
Hi everyone, my name is Promise and I am a second year medical student in Chicago. When I'm not studying, I usually really like to do something with my hands. Most recently, my favorite break from step studying is trying to make the best cup of latte possible. I'm gonna pass the mic to Franco.
Hi everybody, I'm Franco. I am from Peru. I am an incoming PGY1 at Hospital in Baltimore. Outside medicine, I love to make cheesecake with my grandmother's recipe, but I love to play board games. Kirtan is not here, but he's part of the team and he's just such a great addition to this team. So he will come back in the next session. So I will pass the mic to Ravi, Dr. Ravi.
Sure, and hi, I'm Ravi. I like finding joy in medicine books from Reza and also hanging out with this wonderful, fun team that we have here today.
So our objectives for today will be to first explain what is a unit script. Second, why is a unit script important? Third, an approach to unit scripts using the 4W method. And then practicing in making and applying a unit script as a learning tool.
So what exactly is an illness script? So an illness script is a clinical reasoning tool that is used by clinicians to collect and retrieve clinically relevant information about a particular condition to then produce an organized mental summary of a provider's knowledge of the disease. So in the reasoning process, we use illness scripts to compare and contrast a patient's clinical presentation, so the patient's script, against our own mental models of a disease, which is our own illness scripts, as we reason to a working diagnosis or a final diagnosis.
So now that we have defined what is a unit script, why exactly is this important and what is its role? During the reasoning process, history is taken from the patient and processed into data, which includes pertinent positives and negatives from the history, a focused physical exam, and target investigations. Then, this data is translated into an accurate problem representation with semantic modifiers. A good problem representation aims to reduce cognitive load by helping to facilitate problem solving by making the retrieval of relevant unit scripts a much simpler process. Then, we are able to implement pattern recognition, whereby we match the patient's problem representation to an appropriate unit script. As we mix and match the PR to each unit script, one seems to fit and should lead us to the correct diagnosis.
So how is an illness script organized? The data gathered in an illness script can be organized into different categories, which are the 4 W's and the never miss category. The first W is when, which is all about the tempo of disease. The second W is who, which is about the risk factors and exposures the patient has had. The third W is why. So this is the disease mechanism, and this will solidify your knowledge of the condition and overall increase the utility of the illness script. And the last W is what, and these are the key diagnostic findings of the disease, like lab tests, imaging, pathology. And then we have a bonus never miss category, and these are features that are linked to increased morbidity and mortality if the disease is missed. So when we make our own illness script, we have to decide how we fill in each of the 4 W's. And we want to make sure we don't inundate the script with too much information to keep it simple. One strategy to optimize the utility of your illness script is to include a key or defining feature of the disease that helps us distinguish it from other diseases that may have a similar presentation.
So here's an example of a unit script by CP solvers. They outline a script for Crohn's disease using the method of when, the tempo, who, the epidemiology, why or how, describing the mechanism of this illness, and what, the key defining features of this condition.
So in summary, an illness script is a powerful tool to store information about key features of different diseases. It benefits most from the clinical categories that can be useful to compare and contrast when facing a specific symptom, a syndrome, a laboratory alteration, or an imaging finding. And the illness scripts are dynamic, so they should be updated as we gather more information about the disease. And they benefit from our own creativity to make them our own and memorable.
So let's start with the case and practice what we just learned.
Okay, very good. Let's deploy the whiteboard and get moving with the case. And our case presenter will be Shema, and discussants will be Franco and Promise.
So then I will start with the first aliquot. We have altered mental status.
Wow. Right off the bat, this is already a really interesting chief complaint. So I'll just start off. I think when I have a chief complaint of altered mental status, it's always helpful to start with a really broad schema. And I really like to use the MIS mnemonic, which M will stand for metabolic, and that will most commonly be due to electrolytes or organ disturbances. And specifically, I would think about the liver, the kidney, the lungs, and the endocrine system. And for I, that stands for infection. And it's very important in this case to think about whether or not this is a primary CNS infection or if this was like an extra CNS, like a sepsis picture. And also with S, that would be structural causes. So I'm mostly thinking about the hemorrhagic versus ischemic issues, and that would be based on the time course of this presentation. And the last one is T, which stands for toxins. And for that, I will really want to take a good history to see if there are any exposure or any drug use that could be a pivot point for our differentials. That's all I have in my mind right now. Franco, do you have anything to add?
Well, I really want to start out by saying that deploying the mnemonic is really amazing here, because it will help us trigger our next illness script as we get along this journey. But something that I would like to first start here is that when you're thinking about AMS, you must take into account that sometimes if the patient has a dysarthria or if the patient has aphasia, it could be a mimicker of altered mental status. On the other hand, it is always important to know that altered mental status has some never miss features that will prompt us to get treatment over DX. For example, hypoglycemia, we need to give dextrose right away. If there is a risk of opioid overdose, we need to give naloxone right away. And if there is a low Glasgow coma score, we need to intubate the patient. But I think that's all for now. I am eager to know what more info will bring the case. So Shema, can you go ahead, please?
Sure, so great discussion. I will start with the second aliquot. So giving you the HPI, we have a 45-year-old male who was brought to the emergency department for unresponsiveness. His father states that he was unable to wake the patient up and therefore he called the emergency service. And in the emergency department, he was only responding to painful stimuli, and he was alert, oriented 3 times, and he was also admitted to use heroin prior to admission. And in the ED, the patient has also witnessed a generalized tonic-clonic event, and now he is in the post-seizure episode. And again, he was altered, presumed to be post-ictal. And the review of systems was unable to be obtained. And to the past medical history, there is hypertension and substance abuse, and there is no past surgical history. And in social, he lives alone, and his father reports that his son is using heroin, but he denies alcohol, and he doesn't use any medications, relying on the reports of his father, and there are also no further medical records based on that. And that's the end of the second aliquot.
Well, we have a lot of information here, and I think we have a lot of modifiers to alter mental status. So I will promise to take down the seizures modifier, and I will try to focus on the other important modifiers that I could spawn out after this aliquot. So we have the age of the patient, some sort of hypertension history, and the substance abuse history. So if we still use the mnemonic as reference, there are some letters that might be standing out. For example, S. A stroke is always a possibility, even though this patient age is not quite fit in the regular age for a patient with stroke. We know that this patient has already hypertension. So we don't know if this hypertension is long-standing or if this is due to a secondary cause that can put the patient at a higher risk of a stroke. Also, the substance abuse history is kind of important, because if the patient is getting cocaine, he can trigger especially an ischemic stroke, regardless of the age. Another letter that I would like to highlight is T, because some toxins. Although I point out in the chat that opiates cannot be really a source of seizures, but sometimes when people take a drug, it can be mixed with another one. So that could be some toxins that are making the patient have this kind of presentation. I think that's all I have for now. I will let Promise talk about a little more about the seizures.
Yeah, thank you so much for the great discussion, Franco. That's a lot of things that I was also thinking about. So with regards to the seizure, I think we have to first identify if this was a true generalized tonic-clonic seizure or not. Sometimes I think some of the differentials that I'm also thinking could be a syncope or maybe a psychological non-epileptic epileptic seizure. And some clues that can help me differentiate from whether or not this would be a true clonic seizure would be a loss of consciousness, post-ecto status, tongue biting, and loss of sphincter control. That those will be more likely to be a true seizure. But sometimes we have to be aware that, you know, they can be misleading. And so coming back to the MIST framework regarding seizures and altered mental status, I think I agree with Franco. Right off the bat, I want to start with thinking about the toxins, because drug and alcohol abuse can cause seizures, and some medications could also lower the seizure threshold. And regarding the metabolic causes, although this patient doesn't seem like he has many risk factors for that, I think we need to wait until the lab data to really rule that out. And with infectious causes, I think if the patient has fever, then I will put infectious causes higher on my differential. And I also would want to think about, instead of just the primary CNS infections, I want to also be aware of maybe an endocarditis because of his history of drug use. And the altered mental status in endocarditis setting could be due to a septic thrombi causing stroke or a mycotic aneurysm. And these are all the things I have. I'm going to pass the mic back to Shema for the next Aliquot.
So again, great discussion. So I will give you now the physical examination and the labs. So the temperature was 37.2 degrees. The heart rate was 149. Blood pressure 178/129. In general, he was agitated, restless, sweating, and wrist restraints. The eyes, the pupils were equally reactive to light. There was no scleral icterus, and the conjunctiva were non-injected. Coming to the hint, he was normocephalic, the oral mucosa is dry, the neck is supple, there was no lymphadenopathy. And to the respiratory, the lungs are clear to auscultation, but there was increased work of breathing using accessory muscles. And on the cardiovascular, he was tachycardic, but there was no murmur and no peripheral edema was noted. And on the GI, the abdomen was soft, non-distended, with normal bowel sounds. And the skin itself was warm, dry, there was no rash. And on the neurologic examination, he was moving the extremities spontaneously, but he doesn't follow any commands, and he's awake, but yeah, he's not oriented now. And now giving you some chemistry. So I will start with the electrolytes. The sodium is 134, potassium 4.2, chloride 100, carbon dioxide BUN 25, creatinine 0.77, glucose is 105. The total protein is 7.3, with albumin being 4.2. The calcium is 9.5. The AST is 77, ALT 53. The total bilirubin is 1.1, with the direct one being 0.4. And now coming to the complete blood count, the white blood cells we are 21.7. The hemoglobin was 16.5. The hematocrit is 52.9. MCV 94.5. MCH 29.5, MCHC 31, and the platelets 410. And his COVID antigen testing was negative. And they also performed some drug studies, so in the urine, and there was the ethanol levels were below 10, and urine fentanyl was positive. But I will now name some several drugs that came out negative in the urine: cane, methadone, opiates, oxycodone, and PCP. So these were negative, and that's the end of the first Aliquot. And the last one will leave.
Well, really, really a ton of information here, but something that we need to be thinking on the road about this patient. But before we go on, I would like to encourage the audience to write a program representation in the chat. So we can use that program representation when we're doing our special teaching points for the session. You might also see that we have been writing 3DX possibilities, and we are going to use them as well during the second part of the discussion when we compare and contrast the illness script of those diagnoses with our final DX, if we get to the final DX. So let's frame the mnemonics here. So from M, although there are great gross abnormalities in the VMP, and that also relieves me a little because we are not seeing a picture here of a patient with hypoglycemia or hyperglycemia. So I think for a little bit, I can think a little more before giving any treatment. So for I, although there is no fever, that will definitely lower our current differential, but we can still have that DX in the background. I will not add to rule out any infectious disease right now. Even if there's not a hard murmur or something that can lead suspicious of endocarditis, there is also some tests that can be done to definitely rule out that. Because then, as Promise pointed out before, endocarditis can be sort of a septic emboli that could enter there and cause an ischemic stroke. So that's something that I would like to address if everything else comes back negative. For the T and the S, well, the patient indeed has high blood pressure. So it's one of the most important findings here for me. That definitely puts a stroke high on my differential, although the drug screen test is mostly negative. I think that there are some other drugs that are not well picked there. So I think that's something that I need to think about it, but what do you think about it?
Yeah, definitely. And I think we need an imaging as soon as possible because it will really help us clarify some of our differentials. And specifically, I would want a non-contrast CT because it will help us rule out a hemorrhagic stroke. And then I also want to have a contrast CT looking for some kind of maybe gross ischemic abnormalities. But also we have to be aware because if the CT comes back negative, then we would want an MRI so that we can be very sure about our diagnosis. And looking for hyperintensity in key brain areas can help us relate the disease to maybe autoimmune encephalopathies, multiple abnormalities that could relate to maybe malignancy or metastasis. In that case, we'll see a ring-enhancing lesions or even phasogenic edema of the white matter in posterior hemisphere. And in that case, I would probably think about posterior reversible encephalopathy syndrome. That's also known as the Press syndrome. And so I'm going to pass the mic back to Shema.
So now giving you the last aliquot. So performed an MRI mostly in the white matter and basal ganglia and telomere, which was consistent with the vasogenic edema and the subcortical white matter. And this was predominantly localized to the posterior cerebral and that's
Wow, that's definitely a very comprehensive reading of the MRI, and this is a very humbling diagnosis of Press. And I think starting with the missed mnemonic really helped us stay organized and to tackle a chief complaint of ultramental status. And I just learned so much from this case. Thank you so much.
Well, I can agree with more with you, Promise. We kind of framed the case from the beginning with the mismnemonic. We came along with many diagnoses. A lot of the tests came back negative. So I think that this is a good case that will help us to describe the teaching points about the whole script. So it was pressed all the way down. So we are going to the teaching points right now. Can you start, Promise?
Yeah, so I know usually teaching points, this time we're going to do a bootcamp style teaching points. So we're going to walk you through this entire case and dissect the illness script so that you can see how we form this illness script as we get more data in each aliquot, and how we can use this differential and compare and contrast them with our problem representation. So we started with our diagnostic journey using the MIST mnemonic, and in the box you can see a visual representation of the basic illness script that we described in the beginning. And so you can see there are the 4 W's that we talked about, and I think that time is always a good place to start. So I want to just take a step back to reflect on this case first. So we have a 45-year-old male with a past medical history significant for hypertension and substance abuse that presents with altered mental status, unresponsiveness, and seizure. And then we found that the MRI involves a symmetric white matter abnormality that suggests of edema. And so with that, basic on the differential, because this is a very acute time course, I definitely put on opioid intoxication and then endocarditis and press on my top 3 differentials. And with the opioid intoxication, it has to do with the history of drug abuse. And so that fills out the WHO category. And then regarding the endocarditis, I was thinking a lot because this is a drug user. So I was thinking about, maybe this person would have, it fits the picture of an IV drug user, substructural heart disease. It could also be someone with like an intracardiac device or central line placement. And then with the PRESS syndrome, in the WHO category, it would be someone with a past medical history of severe hypertension, which this patient has, on some kind of immunosuppressive status, and maybe they have autoimmune disease or some kind of renal involvement. And then when I think about the what category of these differentials with opioid intoxication, I definitely, if the drug test came positive, and then we have, if this patient has a rapid response to naloxone, they can have seizures. And then with endocarditis, I think the main thing that I would think about is CT or MRI findings, and then having seizure and the Duke criteria. With PRESS syndrome, it fits hypertension, seizures, and also a very specific MRI pattern that we see in this patient. And then when we think about the pathogenesis to complete our illness script, with opioid intoxication, that's definitely because of the opioid receptors being overstimulated. And then with endocarditis, like I said, the vegetations could, embolize and occlude one of the cerebral arteries, and that would be a very acute picture of stroke, or that could be an aneurysm as well. And then in the PRESS syndrome, it would be because of abnormal cerebral autoregulation and the endothelial dysfunction. And it's always seen in like patients with very, very high blood pressure. And these are all the things that I have right now. Franco, why don't I pass the mic to you for you to do more teaching points?
Well, I really love how you frame all the W's here, illness scripts and diagnosis. So what I am going to do now is we are going to go back and rethink about our aliquots and how we did those illness scripts fit the diagnosis when we compare and contrast. So can someone help me with the next, that one? Okay. So we have a Venn diagram that is well known in clinical reasoning. So we have altered mental status using the broad category of the mismnemonic in the middle, and we are going to contrast 3 differentials here. So we have opioid intoxication, endocarditis related stroke, and the posterior reversible encephalopathy syndrome like AMS. that press. So during our first Aliquot, we framed this journey of AMS with the mic, and we started with that. So later on, we learned that this patient has altered mental status plus hypertension history and drug abuse history. So that definitely triggered with our W about the WHO and triggered the endocarditis setting and the stroke. So we can marry those diagnoses and think about endocarditis complications. Then we learned that this patient has not only hypertension, but also seizures. So this patient has an altered mental status plus hypertension plus seizures, and that definitely triggers a stroke. Then we learned that this patient has AMS plus a history of drug abuse that triggered opioid intoxication. Later on, when we have the data from the laboratory, we know that this patient has altered mental status plus a negative drug panel and within normal limits metabolic panel. That definitely triggers PrEP and rule out many other etiologies. And finally, when we got the MRI, we got a patient with altered mental status, a compatible MRI reading, plus hypertension, seizures, a negative drug panel, and within normal limits metabolic panel. So when we compare and contrast that data with all the three diagnoses, we need to anchor with PRES because we have a key finding there, the MRI reading, and we have ruled out all the other things. So that's the way we kind of frame our illness script features when we compare and contrast during each Aliquot in the VMRs. So I think that this is all for now. So if there is any questions, then you can type in the chat, or we can tackle down with them if someone needs to talk. So Ravi, any more input?
Oh yes, that was very good. A remarkable way of showing how you entertain these three possible diagnoses and then walking us through the three diagnoses using the illness script to see what mixed with by mixing and matching, see what really fit this presentation. And I'm just sort of scanning. I've been sitting in the chat and reading a couple of really interesting comments because there's different dynamics to this case. Can we go back to the whiteboard, the first screen? So Travis has an interesting point. 34-year-old weak, or 34-week pregnant young lady who came in seizing. So definitely that brings up the thought of eclampsia and history of failed heroin overdose. Yeah. So with this patient, the first thought, like many people in the chat are thinking, with this heroin on board, maybe the patient had a underlying seizure disorder, and sometimes that could depress a seizure. But giving Narcan could unmask a seizure as well. Say if this patient has been on opioids for quite a long time, they always tell you not to give reversible agents because you may trigger a seizure unless the patient's in obvious distress or deterioration, specifically respiratory depression, that could end up having the patient undergo mechanical ventilation intubation. So I'm not sure in this case if EMS had given Narcan. It wasn't clear when we put the case together, but I assume that's usually one of the protocols in the beginning. But the blood pressure was very high, as you see here, 178 over 129. And then there's another dimension to this, or another angle, that this press meanwhile was going on. And we were just kind of commenting in the chat, like, what exactly is the etiology? I don't think the pathomechanism is known well, but there's always this association or constellation of signs and symptoms. And specifically this imaging finding that Shema described and Promise had walked us through, which highlights this case of press syndrome. Travis, any comments? You had a couple of comments in the chat. Anything that you'd like to share?
Hey, can you hear me?
Yes.
Yeah, so I think, one of the first things that I had mentioned with the case is that, sometimes the case can look like something, or it gets labeled by something, either by EMS or somebody who observed something. And I think, try not to kind of drop anchor immediately on, the etiology of the seizure or why it happened. because after the dust settles and as you all go through your W's and are able to kind of see maybe some particular clinical manifestations or kind of footprints of a disease, you might discover that it's from something else. And I think the press part is really a interesting diagnosis. And I think Sammy had mentioned, like, hey, was it the blood pressure that caused, maybe the radiological footprint you see on CT or MRI, or is it the other way around? Like, what actually causes the endothelial dysfunction? I don't think anybody really knows, but in certain presentations, it can look the same. Sometimes the treatment is the same. Someone seizes from press, you give them benzodiazepines. Someone seizes from eclampsia, you still give benzodiazepines, but in the eclampsia situation, you would want to also supplement with magnesium. And so sometimes you might end up treating two diseases when you really don't know, and that's okay sometimes. But the overlap with some of these syndromes can be confusing. It's just important to not rush to judgment quickly until you have all the information that you have. But this was just a really awesome case, because I think I was thinking so many different things during the history and physical exam and stuff.
Thanks, Travis. That was absolutely spectacular, especially with the different routes that you can take with this case. And very obvious, the first point, like everybody had jumped on, was the opiate overdose. And it's a very difficult diagnosis to make. We've had a few in the ICU, and I think the MRI really does help you make the diagnosis. But I was just going through my illness script. Very important, again, a example of having a robust illness script for this. Or even when you learn this, you take this diagnosis, if it's not in your illness script, and then make sure you have one. So have a new note or add to your illness script. As Madalena had mentioned, an illness script is always evolving and is dynamic. So you start off with a bare bones skeleton of an illness script, and you keep adding, just like Gabriel's case recently of ulcers being GPA. I didn't associate ulcers with GPA, but now I took his case and added that to my illness script. So my illness script is continuing to evolve and change the more and more as I encounter different cases. But anybody have any questions or anything they'd like to contribute?
I think this was a really humble case, because we kind of well over through each Aliquot, and I think that definitely the approach of the 4Ws how like compare and contrast holding script, that was the whole point of this session. So I really learned a lot through this case.
Awesome. I really appreciate you, Franco, Madalena, Marcella, Promise, Deborah, Shema, and I think Kirtan was in the background. He's been busy, but he'll be back for episode 3. But we're pretty much done at 1:41, so I think we can end it for the day. But I really appreciate everybody for coming on and learning about the illness script, and definitely look back at the last episode about the problem representation. If anything else, we'll just say goodbye. All right. Thank you, everybody. Take care. Bye.
Thank you. Bye-bye.
Bye.